The role of point-of-care ultrasound, or POCUS, in evaluating patients continues to rapidly evolve. POCUS is now used to support the physical examination, quickly assess for pathology in many anatomic locations, and guide therapeutic invasive procedures. POCUS is rapid, non-invasive, radiation-free, and cost-effective. This video describes how to use POCUS for evaluation and management of the airway. To identify the upper airway anatomy using POCUS, use a high-frequency linear probe. Hold the probe in transverse orientation and place it at or below the patient's chin with the indicator to the patient's right. Starting at the mentum, identify the mental symphysis and the anterior portion of the left and right mandibular body. Slightly probe caudally to observe the structures of the oral cavity, including the tongue. Continue to slide the probe caudally to identify the body of the hyoid bone, which appears as a hyperechoic semicircle with an associated hypoechoic shadow. Just caudate to the hyoid bone, find the thyrohyoid membrane. Here it is possible to visualize the epiglottis, appearing as a hypoechoic structure. The preepiglottic space is the space between the thyrohyoid membrane and the epiglottis. This image is known as a face sign, where the strap muscles represent the eyes of the face, and the hypoechoic epiglottis represents the mouth. As you continue to slide the probe caudate, view the thyroid cartilage, which is recognized by its triangular shape, resembling an inverted V. The strap muscles can be seen lateral to the thyroid cartilage. The false vocal cords are seen within the thyroid cartilage with the same inverted V-shape orientation. The arytenoids are usually visible as hyperechoic structures on either side of the posterior limit of the vocal cords. Continue to slide the probe caudally to identify the cricothyroid membrane just distal to the inferior border of the thyroid cartilage. This membrane has a hyperechoic density that represents the air membrane interface. Next, identify the cricoid cartilage. The cricoid cartilage is the only complete cartilaginous ring in the respiratory tract. However, its posterior wall cannot be visualized with ultrasound, thereby giving it a horseshoe-like appearance. Moving caudally to the suprasternal notch, visualize the strap muscles laterally, the thyroid gland, the tracheal rings, and the carotid arteries. The esophagus lies either on the left side or posteriorly to the trachea. It takes a round shape with hypo and hyperechoic features. Once the suprasternal notch is reached, turn the probe to the sagittal plane with the indicator pointing cephalad, and, in one view, visualize the hypoechoic thyroid cartilage, cricothyroid membrane, cricoid cartilage, and tracheal rings. The structures of the submandibular space can also be visualized in the sagittal plane with a low-frequency curvilinear probe. Evaluate the submandibular space by holding the probe with the indicator facing cephalad. Visualize the acoustic shadow from the mentum, the intrinsic and extrinsic muscles of the tongue, and the acoustic shadow from the hyoid bone. Predicting a difficult laryngoscopy using POCUS is important for preventing complications and ensuring successful airway management. Several ultrasound parameters have been considered to predict difficult laryngoscopy. To evaluate the distance from the skin to the hyoid bone, place the linear probe in the transverse plane at the level of the mentum with the indicator pointing to the right side of the patient. Slide the probe caudally past the structures of the oral cavity until you visualize the hyperechoic hyoid bone. Measure the distance from the skin to the hyoid bone. A measurement of greater than 1.28 centimeters may suggest difficult laryngoscopy with a conventional laryngoscope. To measure the distance from the skin to the epiglottis, continue to move the linear probe caudally and identify the epiglottis, which represents the mouth of the previously described face sign. Measure the distance from the skin to the epiglottis. Measurements greater than 2.5 centimeters can suggest difficult laryngoscopy. To evaluate the hyomental distance ratio, a curvilinear probe is required. Place the probe in the sagittal plane beginning at the mentum with the indicator pointing cephalad. The mentum shadow appears on the left side of the ultrasound screen, and the hyoid bone shadow appears on the right side of the screen. First, measure the hyomental distance with the head and neck in neutral position. The measurement should be taken as a horizontal line from the mentum shadow to the hyoid shadow. Then, repeat the hyomental distance measurement with the head and neck extended as far as the patient can tolerate. Calculate the hyomental distance ratio as the measurement obtained with the head extended divided by the measurement obtained with the head in neutral position. An HMDR of less than or equal to 1.2 predicts difficult laryngoscopy. Tongue measurements, including thickness, area, and volume, can predict difficult laryngoscopy. Tongue measurements can be performed with either the linear or the curvilinear probe. Place the probe in the sagittal plane, centering the image of the tongue on the screen. Freeze the image and measure the tongue thickness as the perpendicular distance from the surface of the tongue near the hard palate to the submental skin. A thickness of greater than 6.1 centimeters may imply difficult laryngoscopy. Use the same approach to measure the tongue cross-sectional area. Obtain a centered image of the tongue on the screen and freeze the image. Trace the outer border of the tongue. A cross-sectional area of greater than roughly 23 centimeters squared can suggest difficult laryngoscopy. Tongue width is measured using the curvilinear probe in the transverse plane. The measurement is performed at the midsection of the tongue as the distance between the most distant points. This parameter is not relevant on its own, but is needed to calculate tongue volume, which is equal to the tongue's cross-sectional area multiplied by its width. Tongue volume calculated to be greater than approximately 121 centimeters cubed may indicate difficult laryngoscopy. Estimating proper endotracheal tube size is critical, especially for pediatric patients. The smallest diameter of the airway corresponds to the diameter of the cricoid cartilage. To determine this measurement, place the linear probe in the transverse plane at the level of the cricoid cartilage. Measure the transverse diameter of the air column. This measurement allows you to choose the proper endotracheal tube size based on the outer diameter of the endotracheal tube. For example, if the transverse diameter of the air column measures 8 mm, an endotracheal tube with an outer diameter of less than 8 mm is indicated. The confirmation of endotracheal tube placement within the trachea can be performed by direct ultrasound visualization, either in real time or after the intubation attempt. Place a linear probe in the transverse plane at the suprasternal notch. Here, the esophagus should be on the left side of the trachea. It is important to see both trachea and esophagus in the same image so that the structures are visualized simultaneously and examined for the presence of the endotracheal tube. An intubated trachea is recognized by the presence of two hyperechoic lines that represent the inner and outer surface of the anterior portion of the endotracheal tube. Turning the probe in the sagittal or parasagittal plane allows identification of the endotracheal tube by the presence of two hyperechoic lines spanning the length of the visible trachea. The endotracheal tube cuff appears as an aerated structure characterized by multiple A-lines which, if correctly positioned, are visualized within the first three tracheal rings. The tracheal rings appear as oval structures with a hypoechoic pattern. In an esophageal intubation, the esophagus acquires a dilated and circular shape with a double hyperechoic line representing the endotracheal tube. In this instance, the esophagus resembles a second trachea, which has been referred to as the double trachea sign. Emergency front-of-neck access, including cricothyroidotomy and tracheotomy, is a rare but life-saving procedure to oxygenate and ventilate patients with a failed airway. This can be challenging to perform using landmark techniques and digital palpation, especially in patients with indistinguishable neck anatomy. Airway ultrasound can be used to guide these procedures with enhanced accuracy, higher success rates, and lower complication rates. The thyroid cartilage airline, cricoid cartilage airline, or TACA approach identifies the cricothyroid membrane with the linear probe in the transverse plane. Place the transducer on the anterior neck and identify the thyroid cartilage shaped like an inverted V. Then, slide the transducer caudally and visualize an echogenic linear structure that represents the air mucosa interface of the cricothyroid membrane. Continue to slide the probe caudally to identify the cricoid cartilage as an R-shaped structure. Finally, slide the probe cephalad to identify the cricothyroid membrane for a second time. This represents the front-of-neck access point for cricothyroidotomy. The cricothyroid membrane can also be identified in the sagittal plane. Place the linear probe on the anterior neck above the suprasternal notch in the sagittal plane with the indicator pointing cephalad. Identify the tracheal rings as a string of pearls. In some patients, the airway is not in the midline of the patient, and thus the course of the airway in the sagittal plane must be identified first. Slide the probe cephalad to simultaneously visualize the thyroid cartilage, cricothyroid membrane, Cricoid cartilage and tracheal rings. Center the cricothyroid membrane on the screen. Place an indicator under the ultrasound probe on the skin and position it at the level of the cricothyroid membrane. Use the indicator to mark the cricothyroid membrane on the skin. This indicates the correct place to perform a cricothyroidotomy. POCUS is a valuable tool for airway evaluation and management. It can be used to assess airway anatomy, predict difficult airways, confirm endotracheal intubation, and guide cricothyroidotomy. POCUS is non-invasive, portable, and readily available, making it ideal for use in emergency and critical care settings. POCUS education and training can improve patient safety and outcomes in airway management.